Unmute. So last week we talked a lot about diabetes, trying to understand how diabetes works, the differences between type 1 diabetes, type 2 diabetes. I didn't give you any reactions, bummer. Okay. Oh, it didn't go through? Oh, well, how sad, I can't see your reactions. Can somebody tell me what is a main component of type 1 diabetes?
It's triggered.
Insulin,
And
it doesn't
produce
produce
Dormant.
Yeah, I'm hearing a lot of good ones. There's a trigger that happens, it's autoimmune, your body stops producing insulin. Where's insulin made at? Where in the pancreas?
Iceland.
Beta cells, the beta cells on the outside of the pancreas. And just for funsies, what is made in the alpha cells of the pancreas? Glucagon. Yeah, what does glucagon do?
It lowers.
It actually, it stimulates the liver to release glucose. So that's how I always think glucagon glucose, like it kind of like, it's like sugar. It helps to have the liver release glucose or stored glucose. And then how is type 2 diabetes different than type 1 diabetes?
It was,
It's
still resistant.
but you need to keep.
Insulin is the key, that's right. But sometimes there's that resistance, right? Where you need more of those keys to get into the cell, to get glucose into the cell. Okay, so now, and I can't remember which one we're doing, which one of the mentees. I know I labeled it type 2, but I can't remember what we're talking about. So let's jump in. Oh, side effects, what happens? So we're going to talk about what happens when your blood sugar gets too high and what happens when your blood sugar gets too low. I used to think I understood, like, you know, when people are like, oh, I'm just hangry, my blood sugar is low, I need to eat. I had no idea. Like, I had no idea what that meant. Preston, my son, there's sometimes when his blood sugar gets low. Notoriously, it happens at night. And if you've ever seen a belligerent drunk person, that's what he acts like. Like, I'll be trying to like give him juice or candy or something to get his blood sugar up. And he's like, like fighting with me because his blood sugar is low. That glucose, you need it for our whole body, but especially our brain, right? Our brain needs glucose to think, to process, and he's not getting it to his brain. So he is and just it's ridiculous. Usually though, eventually I can shove something in his mouth and then that glucose, our brain's greedy. Usually the first glucose goes to the brain so it can start thinking. And then he's like, oh yeah. And then we'll start drinking the juice or whatever it is I got for him. But we have a lot of different ways that our body can present when our blood sugar is high or low. And here's the tricky thing, just like with a lot of disease processes, there's a lot of overlap. So hypo means low. And now everybody's different. We typically say if your blood sugar is 70 or less, that's going to be low. But like I said, everybody's different. When you guys did your blood sugar checkoffs in the lab, did you check your blood sugar? So did everybody who was at 100 feel the same way? Probably not, right? We all get it, just like with blood pressures, right? We might be a little more symptomatic or feel things a little differently, our heart rates, things like that. I had one patient that I'll never forget when I was working down in California. And they had these first year, like they just finished their medical students. And so she was a doctor and she was very smart, but just not as experienced, right? And she ran up to me and she was like, that patient is hypoglycemic. And I was like, what? She's like, the patient in 403. And I was like, yeah, their blood sugar was 67. And she was like, they're hypoglycemic. And I was like, I know, I gave her breakfast. Because as the nurse taking care of them, I saw her blood sugar was 67 and I was concerned because that's low. But I was there with the patient and I said, hey, how are you doing? And the patient went, okay, it was a good night's sleep, but I'm kind of hungry now. And I said, okay, what did that tell me about that patient? Right? She's stable. She was okay. You know, so I said, okay, well, they're passing trays right now. I'd like you to eat your food, you know, because that's what we're doing to treat that lower blood sugar. She was stable, but we still need to do something about it. totally different story, right? If I came and like that patient was slumped out and like drooling and being the drunk patient person, like my son. But for her, as a new medical student, or, she was just like, she just knew that number, like, oh, that number is low. And I'm like, well, that number was from 45 minutes ago, and she's already eaten and we've treated that low blood sugar. So make sure we always treat the patient, right? Look at them. Yeah. Yeah, so that's another great question. So and thank you for asking for clarification. When it is low, we treat the patient. If it's lower than 70, you want them to eat something, right? Because even if they're not symptomatic now, if they keep getting lower, they will be. They're gonna use up all the glucose stores. Now, with higher blood sugar, usually we mean above 250, but every patient's gonna have a target range. For my son, I like him to be under 200. That's my goal. Last night, I had to wake up in the middle of the night and give him a bolus because his blood sugar was over 300 for a long time. And I remembered when he came home and ate dinner, I thought, oh, he didn't give himself his insulin with dinner time. That's what happened. Because I could look back at my little app and see his blood sugar was really good. And then he ate and his blood sugar went and stayed up there because he ate. He works at Chick-fil-A. So he ate, a fried chicken sandwich and French fries and he stayed up. Yeah.
I have a question.
Yeah.
There's this colleague in West State. He came in the morning and he said, I don't feel good.
Yeah.
And then he went back to the car because he wanted to go home. So he went back to the car and at 12 he was found dead.
Oh my gosh.
Yeah.
From blood sugar issues?
Yeah. When they did the thing, they said he died from hypoglycemia.
Oh my gosh. That's really scary.
I wonder which like what level is too low for someone who's like that?
I've seen patients with blood sugars of 16. That's incredibly low. That patient was kind of comatose. They were like, looked horrible. For that patient, they were in the hospital already, thank goodness. We gave them glucose in their IV several times, and they ended up being okay. Anytime the blood sugar, some people can get symptomatic when they're below 100. Anytime you're symptomatic, not feeling good, that's too low. That's when you need to treat it. Because if you don't treat it, it's gonna keep going lower and eventually you could die. So, and I'm so sorry to hear that. That's really scary.
And I feel like he was, men try to be strong. Because if it was a lady, if I feel really, I'm gonna pass
Say
out, I will
something.
call my friend, I will
Yeah.
try to do something.
Yes.
But I think for him,
Yes. My son, when he was first diagnosed, he used to be a basketball player. And the first time he went to the gym to go shoot baskets, I was so glad I had my little app on my phone. Here, let's see, where is he at right now? It's kind of nice. I can see he's 142 and kind of straight across there. So he's okay. I'm happy with that. The first time he went to go shoot baskets with his dad, and I was able to go see his blood sugars. And so me and my daughter went to like Walgreens or somewhere, I don't know. And I was watching him and he was the blood sugars were trending down. Okay. And then the blood sugars, and I even bought him like an Apple Watch because the Apple Watch, it will connect to this. So I get alarms like when his blood sugar goes low. So I wanted him to pay attention if the blood sugar goes low. Anyway, I watched the blood sugar and it was 100 going lower, 90, 87, 82, 72, 60. It went down to 42. And I started around the 70 mark. I started trying to call my husband and call my son. And I knew where they were at the gym. So I told my daughter Alex, we were in line at Walgreens. I was like, grab that bag of candy, come on. So I just drove to the gym. And as I got there, they had just sat him down because his blood sugar was low and he didn't feel good. But I think I hear what you're saying about not always with men, but my son was a young man who he goes, I said, did you know, why didn't you answer my phone? And then he said, well, because we were playing basketball. And I said, well, did your watch not beep? And he goes, well, I took it off because I didn't want it to get hurt playing basketball. I was like, oh, and that's not what we got it for. And then I said, did you feel anything? You know, because by this time I had him eating the candy, it was little cherry gummy things. I still remember. I said, did you feel anything? Like, how did you know your blood sugar was low? And he goes, I just started feeling really tired. I just thought maybe I'm out of shape because I haven't been to the gym for a while. And I couldn't, he's like, I couldn't even shoot. Like, I just thought I was just really. And so I think sometimes we like to explain away our symptoms, which is why as nurses, it's so important that we teach our patients, like, hey, when your blood sugar is low, you might just feel suddenly very tired. Because even without going to a gym for a few weeks, you should be able to shoot a basketball, right? Like my son, frontal lobe isn't developed yet. There's all of those type of things, but you should know if something is very different, we should look out for it. So it's so important to teach them. With high blood sugars, like I was saying with Preston, I like him to be below 200. I love it for him to be even below 150. When we say hyperglycemia, we usually mean above 250. Most of our patients, we're going to want them to be below that though. Our target range, because remember that A1C, that average number, we want it to be in a fairly normal level because we know the higher that the blood sugars are over time, even if it's just 200 all the time, that can still lead to some negative effects. We're going to talk about that a little bit later. So when we look at the signs and symptoms, one of the biggest things I like to say is, I think I put it on here. Yes, this is also in your weekly resources. So when they're hot and dry, their sugar is high. If they're cold and clammy, they need some candy. So you'll notice that patients with high blood sugar, they're usually warm. And if you touch their skin, it's usually pretty dry. Patients with low blood sugar, they're usually cool and diaphoretic. Like just their skin is, when I say clammy, it's like moist, a little bit wet, not like sweating, but like a little bit sweating. So other signs and symptoms. Do you guys know what pallor means? It's your color is pale, paler color. A lot of times there's shakiness. If you ask somebody to hold out their hand when their blood sugar is low, a lot of times there's a little bit of tremoring that happens. Sometimes they can get a little confused, a little agitated, sometimes blurred vision, slurred speech, and then just like your friends, sometimes even coma and death if it goes on untreated. Now, high blood sugar, usually, sometimes some of these symptoms overlap. A lot of times they feel nauseous, fatigued, slurred speech, blurred vision, agitation. Now, the blurred vision, in my experience, that's more common in high blood sugar than it is in low blood sugar. But it can be sometimes with low blood sugar as well. Okay, talked about that. So hyperglycemia. This one says over 126. I'd throw away the numbers necessarily. We're just gonna say we're talking about blood sugar that's outside of what we want it to be. So why does it happen? So it could be like with my son last night. Why did his blood sugar go so high? Right. He forgot to take his insulin, right? We have a friend that's staying with us right now. He was like, oh, hey, Auntie Carolyn. Came in, wanted to talk to her. He got distracted, was having a great time visiting and catching up with her, but forgot to take his insulin. So either overeating or not taking enough medicine could be both of those. But remember, we just talked about endocrine recently. Remember with cortisol and stress, how that can also increase our blood sugars as well. Same thing with diabetics. That cortisol is still going to have that stress is still going to increase our cortisol and bump up our blood sugars. Most diabetic patients, and it doesn't matter if you're type 1 or type 2, you're going to have some sick day guidelines that they have. Meaning, if they're sick, what do you do? Because first of all, if you have a patient who's throwing up, that's not good. If they're a diabetic and they're throwing up, that can be a pretty serious problem, right? Because first of all, they're not eating, so they're not getting the glucose they need. And if they start to get low blood sugar, they're throwing up, what are they going to do? They're not really going to absorb much, right? Do you guys know if somebody is like maybe not mentating very well, they're not maybe able to drink some sugar or eat something, what you can do for them if you don't have like glucagon?
Frosting.
So I love the idea of juice. Sometimes they're not even awake enough to swallow and we don't want them to aspirate. So frosting or honey or some sort of thick sugar, Caro syrup, and you put it subbuccal under the tongue. Because remember, when we talked about in lab medication administration, subbuccal medicines, they dissolve and absorb very quickly because there's so much blood flow through that underneath part of our tongue. I've done that before with my son. Sometimes he's been really low. I didn't use honey. I just got a little bit of sugar and poured it underneath there because he wasn't okay enough to eat or drink anything. So I just put something under there. So that's something I hope you don't have to use, but in your career, if you're taking care of a diabetic patient who's not able to eat or drink, they don't have an IV where you can give them glucose, so there's no options. You can do under the tongue, some sort of simple sugar. Don't throw meat or something like that under there, right? Because that's like a piece of meat is not gonna absorb under the tongue. Okay. So symptoms of hyperglycemia. Remember we talked about the 3 Ps? You guys, what are the 3 Ps? Yeah, polydipsia, polyphagia, polyuria. We talked about some of all of these with hyperglycemia. Sometimes we can see ketonuria. We're going to talk a little bit more about that, so I'm not going to get into it a whole lot right now. So if we have high blood sugar, what do? We got to treat it, right? So first thing, we've got to check the blood glucose, right? Because we can guess, right? Because some of those signs and symptoms are so similar. If you're taking care of a diabetic patient, they might say, I don't feel good, they're agitated, they have blurred vision, they're confused. Those are things that could be either high or low blood sugar. So we need to actually check the blood sugar so we know what it is. If it is high, then typically we're going to administer insulin. Now, if this is a type 2 diabetic that does not take insulin, they just take oral medications, they might give them a little insulin, but that would usually just be in the hospital setting. Typically, as an outpatient, if your blood sugar is high, you don't just start giving somebody insulin like for a type 2 diabetic. We want to check the ketones, especially those type 1 diabetics. If their blood sugar has remained high for a while, we want to check their urine and see if there's any ketones that have started building up. We want to see what the cause was, right? Last night, my son forgot. So that was the cause. I treated it by giving them some extra insulin during the nighttime. Then we want to tell patients, if you're at home and your blood sugar over, for this slide, it says 180. Every patient's going to have maybe a little bit different goal, but it probably will be around that. You say, hey, your blood sugars are over 180, over 175, something like that for 2 days, and you're doing all the things you should be, you need to call your doctor. And then we always want our diabetic patients to call their healthcare provider if they start vomiting because of the risks of having low blood sugars as well. Okay, so I want you guys to think about this for just a second. You are visiting a home care patient, or you're a home health nurse trying to reinforce teaching about care of a newly diagnosed type 1 diabetes. When you arrive at the home, the patient's lethargic, can't even answer questions, and he's asking for water. So turn to somebody next to you or somebody close to you and think, say, what would you do? If you're the home health nurse, what are the things you would do? What steps would you put them in? All right, let's compare what you guys had with what F.A. Davis recommends. Oh, I didn't click back in. So we're going to check the blood sugar, right? Because we're suspecting it's probably low, but we need to confirm. Then we're also probably going to want to check urine for ketones as well. We're going to give them some water because we're going to learn about that. Wait, hold on. We don't think it's low. We think it's high. Sorry, I said that backwards Because remember, hot and dry, sugar is high usually, and they're thirsty. Cold and clammy needs some candy. Yep, hot and dry, the sugar is high, cold and clammy needs some candy. And that picture is in the weekly resources. I have that picture along with some other ones to help you remember in the weekly resource page. Yeah.
So if it's type 1, then giving them some Karo syrup or something thick, that's not gonna help.
Well, for this one, the blood sugar is probably high. So we don't want to give them any more glucose. We want to actually probably give them some insulin. So like it says, lethargy and thirst, those are signs of high blood sugar. Because he's type 1, he's pretty at risk for dehydration and ketoacidosis. We want to see if there are ketones. And then we need to consult the healthcare provider, the RN, to see if there's insulin orders. All right, so management, when we're talking about managing type 1 and type 2, and we've talked some about this already, type 1, there's usually not oral medications, right? Because remember how you guys acted out, like how those oral medicines worked? That's usually when your body already has, you're making insulin, right? It's making the cells more receptive to insulin. It's stimulating the pancreas to produce insulin. Sometimes it's slowing down digestion, so you have slower release of the glucose in your system. But if you don't make insulin, that's not going to help you, right? So usually type 1 diabetics don't have oral medication. They do need insulin, but exercise is going to help them, right? Just like it helps everybody be healthier overall, it's really good to have good exercise habits for diabetic type 1. Hypoglycemia. Question for you. If you're caring for a client with a low blood sugar, which glucose level would you observe? What are we typically, what number would we see for less than for low blood sugar? All right, and you guys are fantastic, right? Less than 70 is typically what we'll see. I did notice with my son, when he started getting below 100, when he was first diagnosed, he would start getting signs and symptoms of hypoglycemia. His blood sugar would hit about 98, 97, and he would start getting a little tremors, feel a little shaky. Why do you think that was?
Normal blood sugar is higher.
Yeah. His blood sugar was 600 and some when he was diagnosed. So his blood sugars had been really high for a while. So he was used to having a lot of high blood sugars. Remember when we talked about hypertension and hypertensive emergencies? We don't want to drop them down too fast. It's kind of like that with blood sugars, where we don't want to keep him up in the 400s or 300s. But when he starts getting symptomatic at 100, then it's like, okay, we're not going to, we don't want you to go below 100 for right now. We're going to give you a few weeks to kind of normalize and get you down to a normal level. Because if you have hypoglycemia, even if it's just from 100, you're still not thinking well, you're not going to do well, you're going to have impairment. So his body gradually adjusted, where now there's sometimes his blood sugar goes down to like 60. And I'm like, are you okay? He's like, Mom, I'm fine. I already ate something. You just haven't seen it come back up yet. Which we'll talk about that in a minute with glucometers. Okay. Well, we talked about this already. Sometimes I like to say hypoglycemia. It's kind of like that fight or flight symptoms, like when you have anybody almost get in a car accident, like somebody cuts you off or something happens and all of a sudden your heart's like, and you're just like, ooh, like that's that fight or flight response. That's kind of what it feels like a little bit is what people have said. So sometimes a little bit of shaky, you're like all kind of jacked up adrenaline. That can be similar to what we feel or what patients feel when they have the fight or flight or when they have low blood sugar. You can have seizures. Your blood sugar goes too low. They can have diabetic seizures from the blood sugar being too low. If they have autonomic neuropathy, so somebody that maybe has some autonomic issues like disease processes, they might not have the same signs or symptoms. So just know if you have a patient that has some autonomic issues, how they present with high or low blood sugars might be different than the average person. So just something to keep in your back pocket. So treating it. So first, we always want to check, right? We always want to make sure we know what the blood sugar is. And then we're going to give them 10 to 20 fast-acting carbohydrates. Who can tell me what's an example of fast-acting carbohydrates?
Brown crackers,
4 ounces of orange juice.
Banana.
apple juice.
I would say juices over the graham crackers because of the absorption, right? Fast acting means what's going to get into your system and quickly absorb. I think graham crackers have a bit of fiber in them, if I'm remembering correctly.
So it'll slow that.
Exactly. The fiber in the graham cracker will slow down how it digests, and we want it to be quickly digested and quickly released. So typically a juice, a sugar, this is where I tell people, like, there's a candy that you like. Do you like Skittles? Yeah, keep those Skittles in your pocket or in your purse, and then you can have them. I mean, it's not for fun, but at least you get to have something that you like. Sometimes people have glucose tablets. They're like little chalky, they're like gross. If you've ever like tried one, I tried a little bit of one. It was so gross. I can't imagine feeling nauseous and hypoglycemic and then having to chew on one of those. I'm sure they're fine for some people and that's what works for them. But find a sugar that you'd rather enjoy eating if you're already like not feeling good. You want to wait and check in 15 minutes. Usually they say, if you feel up to eating more, you can, but you want to, in 15 minutes, see where your blood sugar is at. There was one time when my son accidentally gave himself way too much insulin, like way too much insulin. And so we spent several hours working on keeping his blood sugar high, not high, like above 70. Because he miscalculated. This is early on. He was doing his saying, okay, I'm going to take this much insulin if I eat this much. Well, he did the dosage wrong, right? We all know about dosage. And he gave himself way too much insulin. And so I didn't realize it at first. And then I was looking and I was like, why does he keep going so low? And then we talked about it and I was like, oh, that's why it's really important. We're going to talk about insulin timelines later, because I knew that he took Humalog. And then anybody know the duration of Humalog? Should be on the sheet in front of you. Humalog or Novolog? Yeah, what's the duration on Humalog or Novolog? What's the duration of action? 3 to 5 hours. I knew from my experience with working with my son, about 4 hours is about how long I could see effective insulin. So I sat with him in his bed. And this is one of the times I use sugar too, because he was drinking juice just to keep his blood sugar high, above 70. And every, 10 minutes or so, I'd be like, okay, drink some more. Drink some more. And then he got to the point where he just felt too full. He was like, I just keep drinking juice. I feel like I'm going to throw up. I can't. And then I was like, okay. And so I got little spoonfuls of sugar and I put them underneath his tongue about every 5 minutes. Because I was like, we have to do something, right? We have to keep your blood sugar up until the Novolog wears off. That's why it's important you guys know when you give insulin, how long is it going to last for? Well, first, when does it peak? When does it have its maximum effectiveness? And how long does it last? Because when you first give insulin, does it work right away?
Yeah.
Some of them, right, know what we're giving. Some of them, like Novolog or Humalog, can start working within 15 minutes, right? They work pretty quick. What is the peak time for Novolog or Humalog? So when should you be checking on your patients after you give them the Humalog or Novolog? About 1 to 3 hours, because that's going to be the peak effect. Because what happens if you give them their tray, and Cassie, you're my patient, and you say, oh, I love French chip sandwiches or something. I don't know. You're like, I can't wait to eat it all. And I give you your medicine, but then all of a sudden I come back later and it's sitting there and you were like, oh, I got a phone call and I got distracted and now I don't feel good and I'm confused. You got your insulin, but you didn't eat. And about an hour later, we're going to see that peak effect of how it's working. So it's that's why when we talk about insulin, we're going to talk about timelines, because it's so important to know, because blood sugars have such a big effect on our well-being, on our mentation. We need to know when they start working and then when the peak is, because that's when I need to be rechecking with them. Just kind of like pain medicine. When we administer pain medication, our patients are in pain and we give them oxycodone or Percocet, you know, we're not gonna come back and check with them in 15 minutes because it's not gonna start working yet, right? Usually about half hour to an hour is when we're gonna see the peak effect of that medication. So that's when we're gonna come back and check and say, hey, was that pain medicine effective? And hopefully they'll say, yeah, it was. But we're checking on them because we want to know, is it better or do we need to do something else? Or did we just give them way too much medication that might, you know, make them pass out? We're checking on them during peak effect. Oh man, I went off on a really long tangent. So let's bring it back. Okay, if it's going to be longer than a half hour and you've treated them for low blood sugar, this is when you want to give them a snack. Something with a complex carbohydrate that has, like, it's going to last longer. Those simple sugars, they'll boost your blood sugar up. They don't last long. Comes right back. Your blood sugar will come right back down. Things with fat, protein, and fiber, those are going to kind of bring your blood sugar up and going to keep them up for a little bit longer. So we want like cheese and crackers or milk, graham crackers with some peanut butter, something that's going to keep their blood sugars up for a little bit longer is going to be necessary. Here's some fast sugars. They put raisins on here, but who eats raisins? I mean, I like raisins, but I don't know if I'd keep them for like diabetes. Okay. We just talked about this. I'm just gonna go past it. Glucagon. Glucagon, we talked about our liver, our pancreas produces it, but this is also, we mimic it. We give it as a medication. So let me see. Will it not play? Uh, well. Oh my goodness. Okay, tell you what, let's take a break and I will pull this up. Do you guys want to do a little bit of a longer break now so you can get lunch and shorter break later? A bit, I'm hearing more yeses than no. So how about let's come back at 12:45. So get some food and I'll adjust these videos. I will show you the Glucagon injection emergency kit. Kit contains everything you will need to treat a burdensome low blood sugar. Kit contains a vial with the dry glucagon powder and a pre-filled syringe with liquid inside to mix with the powder. The needle is already attached to the syringe. You will need to mix the dry glucagon powder with the liquid before giving the injection. Pick up the vial containing the dry glucagon powder. Using your thumb, flip the cap off the vial. Set the vial down on a flat surface. Pick up the syringe. Remove the cap covering the syringe needle and be careful not to accidentally stick yourself. Insert the syringe needle into the rubber stopper on top of the vial. Push down on the syringe plunger handle to inject all the liquid into the vial. Without removing the needle from the vial, pick up the vial and syringe with one hand. Gently swirl the vial until the dry powdered glucagon is completely dissolved. The solution should be clear and colorless. Do not use it if it's cloudy or if you see particles in the solution. Using both hands, one on the vial and the other on the syringe, turn over the vial and syringe so that the vial is on top and the syringe is below. Holding the syringe, pull the syringe needle down until the needle just shows above the top of the inside of the rubber stopper. Pull back on the syringe plunger handle until all the liquid is drawn into the syringe. The vial should be empty. The syringe should not contain air. If there is air, using your thumb, push the syringe plunger handle so that air goes back into the vial, but not the liquid. Now, pull the syringe needle completely out of the rubber stopper.
Select a site for injection. Glucagon can be injected into the thigh, buttock, or upper arm. If you are unable to remove clothing in a timely manner, glucagon may be injected through clothing if necessary. With one hand, gently.
Okay, so just to pause really quick. So this, to me, it was kind of dumbfounding when my son was discharged from the hospital. And that's what they gave us for our emergency medicine if his blood sugar was low. To me, even as a seasoned nurse, I'm like, reconstituting in an emergency? And then to think, okay, now I have to prepare my husband, my daughter, my loved ones, and teach them how to reconstitute, how to give an injection. Most people are fairly familiar with like an EpiPen, like we've done a lot of good national campaigns for health, and so people know how to do that. But this is very different, right? I was very nervous. I want to show you something else because this is still widely out there. This is what a lot of patients have. So imagine not only having to teach them how to manage diabetes, you also have to teach your patients how to reconstitute medications and how to give IM injection as well. So it's a lot. Excuse me. I was really excited because I heard a few months after he was diagnosed about another form of glucagon. Before I get there, have you guys heard of Narcan? Right? Narcan used to be injected, but they discovered a new way to give it to patients where it could be inhaled or intranasal. They've done the same thing with glucagon, where it can be a nasal inhaled spray. So I'm going to show you, I got him the prescription for this. I'm going to show you a video. So think about all the steps of what was in that previous video when we compare to this one.
Caution. Do not press the plunger before insertion into the nose. Otherwise, a single dose in the device will be lost. Hold the device between fingers and thumb. Do not press plunger with a test device. Insert the tip gently in the nostril until the fingers touch the outside of the nose. Push the plunger all the way in with your thumb. The dose is complete when the green line on the plunger no longer shows. Remove the tip from nose and throw away the used device and tube. If the person with low blood sugar is unconscious, turn the person to their side. Call for medical help right away. Encourage the person with.
Okay. How different was that? Like all of the steps of going through and reconstituting, pulling up, giving an injection versus an intranasal, like so different. As soon as I heard that was available, I was like, what do I have to do to get that for my son? Because I knew that if I'm not around, people are going to be a lot more likely or more comfortable doing this one. So that's something that, guys, some of you might even get involved in research and other things, because I'm certain that it was somebody who was looking at that glucagon multi-step process that was like, okay, we've got to have a better way, right? There's got to be a better way or an easier way we can do this for patients, and then came up with this idea. So get into research, right? Find things that like vibe with you. You're like, oh, I want to be able to do that for patients. I want to make things more accessible. Or if you're out working, maybe you're in a clinic and you're like, oh, this person's health literacy is really low. Maybe a mom has a kid who's diagnosed with type 1 diabetes and she has rheumatoid arthritis and she can't use, she's got low dexterity, right? That's going to be really hard for her to do all of those things. Ugh, let's not even talk about insulin pulling up. Anyway, right, let's point our patients towards the resources that are going to be most effective and easy for people to be able to administer. Because anyway, it's just something that I want us all to be aware of. So it's really super interesting. Inhaled glucagon. One thing, remember I showed you the picture of Preston when we talked about upper respiratory and he's got that deviated septum? What's something when you're giving medicines this way we have to think about with that? Right? Which side do we use? Right? Because if we put it on the side that like my son is deviated like this, I think. And so if we put it over here, it's all blocked off. It's not going to go anywhere. He just went on another winter camp with our church last weekend, and I had my little best, it's called Best Gummy. It's an inhaled glucagon. And I wrote on it, I said, right nostril, because I wanted them to see it. Like if something happened, they would know, put it in the right nostril because left wouldn't do a whole lot. Anyway, it's just super interesting. So there's lots of different ways out there, and there's going to be more medicines and more things that keep coming up, which is why it's so important that we're aware of current health trends and new medicines and new things, because there's going to be some things that work way better for people than maybe other things would. And we want to be able to help our patients with that. Okay, going back into the Menti. We're almost done with this first one. I want to talk just a little bit about diabetic ketoacidosis. We've talked about it a bit already. Most common in type 1 diabetes, especially the three things I think we usually see, and we say, when we say diabetic ketoacidosis, we call it DKA. DKA is how you're going to see it abbreviated in the medical chart and terminology. Usually you'll see it for medical noncompliance. I used to see it a lot in people who are ages 18 to 20s, early 20s, because they moved out of their house. They were managing their diabetes for the first time on their own, and they didn't want to do all the things, kind of rebellion a little bit. And so that's usually when I would see them, and they would come into ICU and be in DKA. I'm hoping we're not going to see that nearly as much with this new generation of young adults who have access to continuous glucose monitors, to insulin pumps. It's a whole new generation that I think we're going to see. We also can see DKA with stress and illnesses as well. We talked a little bit about sick day guidelines. When you're sick, that cortisol response, the stress response, drives your blood sugar up. So oftentimes our diabetic patients need higher doses of insulin or higher doses of medication when they are ill. Sometimes at home, they can't keep up with it. The demand is too much, and they have to go to the hospital to help keep from going into DKA, or sometimes they go into it. So we talked about how with the pathophysiology, you don't have enough insulin. Your cells are starving because there's glucose available to get into the cells. So to make energy, they're breaking down fat, breaking down proteins. The byproduct of that fat breakdown are the ketones. So we excrete the ketones usually through where? Urine, right? So people pee it out. Olden days, long time ago, you know how old doctors like centuries and centuries ago, you know how they would test? They would taste the urine. The patients would pee, because it's usually first thing in the morning. Patients would pee, and the doctors would come and they'd taste it, which is so gross. But what would it taste like? Sweet. It had extra sugars. They were just like blowing sugars off in their urine as well. So gross, but it kind of tells you something. Ketones also, we breathe them out a little bit, not breathe, but it changes our breath. You guys remember in the reading what the breath smells like? It's like a sweet, fruity smell. So remember we talked a little bit about those Kushmal respirations, where you kind of have the fast breathing and then slow and then fast. You see somebody like that, and you're getting close to them and you're like, what smells so sweet? It might not be their perfume, right? It might be their breath that being so sweet. Signs and symptoms, a lot of times flu-like symptoms, right? Their blood sugar is really high. So sometimes they just feel achy, they feel tired. Similar to signs of the hyperglycemia, like we just talked about earlier, but they might have the Kussmaul respiration, fruity breath. There's a lot of electrolyte imbalances that happen. I think I linked a video in the weekly resource page, but insulin and potassium are kind of linked together. As insulin goes into the cells, so does the potassium. And so if insulin isn't going into the cells, sometimes we get potassium that builds up on the outside of our cells as well. So there's some electrolyte changes that can happen in this. These patients they get very dehydrated. Eventually it can lead to coma and death. So what do we do for it? Well, you guys, unless you're working in ICU, are probably not going to be actively taking care of it, but you need to know what they need, right? So if you're working in an ER, urgent care, and you see something, you're gonna know, okay, they need to get IV fluids and we need to give insulin to bring their blood sugars down. Usually they're on an insulin drip, which means it's like an IV infusion, very tightly monitored, right? Because insulin is one of those high risk medications. And so if you have a patient who has an insulin drip, like insulin infusion, that's one of the ones where anytime I make a change or every shift, there's gotta be 2 nurses. And even like with RNs, 2 RNs, like together, both of them checking off that this is the correct amount because it's such a high risk medication. Prevention, right? So when teach patients about their sick day guidelines, if they're starting to get sick, sometimes with my son, even if his blood sugars aren't really high, but if he's starting to get sick, sometimes I'll say, you know what, we just go check your urine for ketones. Because sometimes I might not see his blood sugar go really high, but he might start making ketones because of his body's just demand with being sick. And so anytime we see ketones, the first thing we do is drink a bunch of water. That's one of the best things to do. If you have high blood sugar, drink water. That really helps. Ketones, drink water. That it will really help to lower the blood sugar and flush away those ketones. We have another diagnosis issue, pathophysiology. We almost always call it HHNKS because the long words are hyperosmolar, hyperglycemic, non-ketotic syndrome. That's a lot to say. It takes a long time. So HHNKS is pretty standard, but it does help us understand what it means, right? So hyperosmolar, right? The like osmosis, right? Diffusion, concentrated. Hyperglycemic, high blood sugar. Non-ketotic, non means no, so no ketones syndrome. So it's just something that happens. So that lets us know somebody very concentrated, very high blood sugar, but no ketones. That's kind of what this is. Usually it's type 2 diabetes that we see this in. Stress, illness, just like kind of with type 1 going into DKA, a lot of times you'll see this more in the elderly. Remember, as we age in our elderly population, we don't always present the same way. Just like what's the most common sign and symptom for an elderly person that has a UTI? Confusion, right? In somebody our age population, confusion would be the first thing. Just like if our blood sugars were really high, we probably would present differently than somebody who is elderly. Elderly, they don't have the same signs and symptoms. They don't often get treated or seek treatment the same as somebody else with the number of symptoms. Your blood sugars can get very high. Excuse me. So glucose gets elevated. They start having that polyuria, right? They're trying to pee out all the extra glucose. They get really dehydrated, like profound dehydration with these HHNKS patients. They usually don't get nauseous and vomiting because they don't have those acidic, the imbalance like with the type 1 diabetics. They don't get those ketones that develop. They're slower to get help because of that, and there's a higher mortality rate with these patients. They're really lethargic. Their glucose levels can get 1,000 to 1,500. So high. Like that's where you just see these crazy high blood sugar numbers. Because of that, their electrolytes are all out of whack. Also, just like DKA can lead to coma and death, therapeutic interventions, they're just like DKA, right? Just like type 1 and type 2 diabetes have same risk factors and same things. Both of these ones, even though it's usually type 1 or type 2, right? Type 1 has DKA usually, type 2 is usually HHNKS. We still do the same treatment, right? We're going to give them IV fluids, IV insulin. We're going to manage those electrolytes. They're going to be getting essentially the same treatment for them. Prevention, SMBG, I don't, you guys saw that in your book. It's self-monitoring blood glucose. I don't see that all the time, but I wanted to put it in here just so you guys know, SMBG, self-monitoring blood glucose. Which patient should be monitored for Kussmaul respirations? Is it the patient with type 1 diabetes out of control, patient with new diagnosis type 2, patient with metabolic syndrome, or patient with gestational diabetes? Yeah, so patients with type 1 diabetes that are out of control, that's who we're going to monitor for the cousinol. So why, just think for a second, and actually you don't even have to type it in because I feel like that takes forever. Think in your head, why do patients with HH and KAS don't have the pH imbalances? And then share it through a person next to you. All right, so remember with HHNKS type 2 diabetes, they're usually still producing insulin, right? Their body is still making insulin, so they don't need to break down fats to get energy. But that breakdown of fat is what causes those ketones to develop, very acidic. Those are what causes those acid-base imbalances.
So is it metabolic acidosis?
Yes. Yep, they're usually acidotic. All right, so now hypo or hyper, you tell me, if I give you a symptom, you tell me hypo or hyper. So if they're hot and thirsty, is that hypo or hyper? And if you're not logged in, you can just like point up or point down. Totally. Hey, nice job. So what's the saying?
When it's hot and dry, sugar is high.
Yeah, hot and dry, the sugar is high. Yeah, cold and clammy. Do I have that?
Yeah.
So what about shakiness and tremors? Yeah, this is usually with hypo. Good job. Cold and clammy. Cold and clammy, what do they need? Need some candy. Cold and clammy, need some candy. What about confusion? This is one of those tricky ones. It could be both. Usually I think of confusion more with hypo, but it could be with hyper as well, which is why it's so important. We don't just treat without checking the blood sugar. Agitation, irritability. This is another one. It could be both. I usually think agitation more hyper actually, just because I think about it with my son. Like last night, if I would have talked to him later before I went to bed when his blood sugar was high, if I would have said, "Hey, did you give bolus with your dinner?" He'd be like, "Mom, like, like hopefully respectful. But he definitely gets a little more agitated when his blood sugar is high. Right. And so that's just one of the things, like they just get a little like just irritable with hyper. But I mean, you can with hypo as well. It just I feel like I see it more when it's high. Slurred speech. This is another one. It could be both. I feel like we see it more with low blood sugars. Blurred vision. It can be both. Hyper is where we see it more. There was one time my son was, when he was first diagnosed, and I think we were still doing COVID stuff from home. And his blood sugar was really high. I was trying to do schoolwork. And he's like, "Mom, I can't." I'm like, "Well, we just gave you insulin." And he's like, "I can't see right." And I was like, "What do you mean?" And he goes, he picked up his laptop from school. He goes, "This is like, this screen is what all I can focus on. Everything else is blurry. And it's going like this." I was like, "Oh, that's a really good example of like his blood sugar was high and he just couldn't see quite well." Which leads me to a really good point, kind of off topic, but when he started driving, what do you think was really important that we stressed with him? Like blood sugar control, right? That was one of the things we taught him. Like, you want to drive, the first thing you get in the car, for him, it wasn't buckle your seatbelt, it was check your blood sugar. What is your blood sugar? If it's good, then you can buckle your seatbelt and then you can drive. Okay, that's the end of that one. Let's just hop right into the second one, and we're going to talk about insulin and side effects, I believe. And since we've already talked about some of it, I'll skip over some. So go ahead and join here on this guy. And I've also written the code over here. Okay, gonna move through and skip over some of this. Okay, so this is where that SMBG, self-monitoring blood glucose, just glucose monitoring. So at home, how are patients going to monitor it? Typically, if they're checking a blood sugar, like a finger stick, we say, take it like in the morning when you wake up before breakfast. So before meals and at bedtime. We usually want to make sure that the patients know to record the results, know what the results mean, know what their target is, and then when to call the doctor. Those are kind of our big goals with our patients. So glucometers. This is probably a type of glucometer you guys maybe checked often when you were in lab. Sometimes our long-term care facilities will use little glucometers like this. You might see there's so many types of little glucometers. They're everywhere. This is a glucose diary. Super important that patients know not only what their blood sugars are, but to record it down. Their glucose monitor usually will keep a record of it, but sometimes it's not as accessible. So we want patients to write down things and even have notes like this one, ate cake at Betty's party. So where is that here? At supper, she said at 3 p.m. because at lunch she was 97. At supper she was 302. Oops, she did eat some cake, right? So it's good that they know to monitor blood sugars, but also be able to reflect what made the blood sugars go higher or lower. CGM stands for continuous glucose monitoring. Initially, these were targeted more for type 1 diabetics, but they've expanded to be now with type 2 diabetics as well, because we found that regardless of what type of diabetes you have, having a continual monitor, knowing all the time where you're at is helpful. Because I keep losing my phone. I'm so silly. With my son, we'll do like this. It's really good to know, like right now, he's 135 and pretty stable, right? If we were to do a finger stick right now, 135, I'm like, okay, I'm happy with that. If I would go, I don't know if you guys can see this little like yellow line, the mountain. That mountain, I did a 24-hour view on this. Last night, he was like almost 400. That's why that mountain was there. He forgot to give the insulin. If he didn't check his blood sugar at night, or if he didn't have a CGM, we wouldn't have known that it went so high at night. So for type 1 or type 2, it's so nice to have these because it kind of tells you like, hey, you were really high last night. What happened? And then they can be like, oh, I forgot. Or maybe something, who knows? We can look into it. Okay. Types of CGMs. A lot of times, I think this is the Freestyle, like the Libre or something. And so these ones are somewhere like this type, there's a little thing and you have to hold your phone up next to it or hold the device, and then it will show you the sugar meter on the device. There's other ones like this one that I'm showing you now, like this Dexcom is the name of it. It just transmits automatically. And you can have other people that follow you. Like my mom still follows my son, so she sees what his blood sugars are. And she goes, I know when he goes low at night, I pray for him. I'm like, thank you, Mom. It's very sweet. And most of these, this one's a better picture. It's injected into the skin. It's kind of usually good for about 10 days. It goes into the subcutaneous tissue. So one thing that's good to know is that they're very accurate, but there's a little bit of delay. Just think about when we do a finger stick, what are we checking? We're checking the blood, exactly. When it goes into the subcutaneous tissue, is there blood that's there? Not really, it's the interstitial tissue. There's about 15-minute delay between your blood glucose level and the interstitial tissue that's kind of in our fatty cells. So sometimes with my son, I'll be like, I remember early, there was one time I went for a walk because I thought he was fine. And he called me, goes, Mom, something's wrong. I looked, I was like, your blood sugar is fine. It's like 100, pretty solid. He goes, I don't feel good. I already started to drink some juice. I turned around, started to walk home. As I'm looking, it's just tanking because he could feel it, but there was about a 15-minute delay between what was going on in his blood and what was getting picked up in the interstitial fluid. So no, they're very accurate. They're very good. A lot of times if patients are in the hospital or long-term care, the providers will write orders to say, you don't have to do finger sticks. You can look at these devices. You can use those. But just know there might be just a little bit of a delay on the time of them. Okay. Urine testing. Way back 50 years ago, after not when they were testing, but they would check urine for glucose. They didn't have the technology to detect the blood for glucose. So as urine had glucose kind of spilling out into it, that's what they were checking and measuring their blood sugar control. Can you imagine how hard that would be to like not even know what your blood, they didn't even know, they couldn't even test a blood sugar at home necessarily. Crazy. We don't really do that anymore at home, but we do tell our patients, we teach them how to test for ketones. If there's trace ketones, we just say, drink some water. Moderate ketones, we say, well, drink some more water, see what, kind of keep an eye. If it's high ketones, usually we have them have a guideline for them to follow, which if it doesn't resolve within a certain amount of time, we have them go to the emergency room. So medication, we've already talked about this last week. Reset the results. Oh, wow. Okay. Well, here's the big shocker. How can insulin be given? Did you guys know it can be also given inhaled? There's some inhaled insulins that they have now. Super cool. I looked into it a little bit for my son, but he really wanted it pumped. But if you think about the surface area of our lungs, right? It's about, if you would take the surface area of our lungs and spread it out, it's like the size of a tennis court. Yeah, it's so huge. And so it's so interesting, like the amount of medicine that can be rapidly absorbed. Usually we give insulin, subcutaneous is going to be how you guys are going to majority of the time give insulin. So pull out your little sheets that I gave you, the timelines, the insulin timelines. I want to make sure you guys know there's different types of insulins. Back when I was first starting as a baby nurse, we only had fast acting insulin. We didn't have the rapid acting. I think I'm saying that right. Because under short acting, or excuse me, short acting, thank you. We had regular insulin. Then, shortly after I graduated, they developed these rapid acting insulins. What are some of the big differences you see with the short acting and rapid acting insulins? Yeah. Because our bodies are so amazing. A lot of you guys went and got food recently, right? You just went and got coffee, got a snack. As you ate, your body worked wonderfully. And those beta cells just started kicking out just the right of insulin to match what you were eating to keep your blood sugar stable. Like, it is just amazing to think about that. Diabetics, if they're taking insulin, have to think about, what am I going to eat? How many carbs does it have in it? When am I going to eat it? And then there's more things we'll talk about too. And so they have to time it out. Like if they're taking regular insulin, when should they take that? Like how far in advance before they eat should they take that?
30 minutes to an hour.
About 30 minutes, right? Because what you want to do is give the insulin and have it starting to work as you eat. That mimics what our body does, right? Because if we give the insulin as they've eaten or after they've eaten, their blood sugar's already gone up, right? The insulin is kind of trying to play catch up a little bit. What about if we are giving food to somebody who's on Humalog or Novolog, who's rapid acting insulins? How far before they eat should we give it?
You should get it close.
Pretty close to the time. Usually it's about 15 minutes for the onset. Here's the thing. In the real world, in nursing that you guys are going to do, it's going to be almost impossible to do this. When we teach patients about going home, this is when we're teaching them. You know, my son, if he's doing well, he'll give himself insulin. Sometimes I forget. And I'll be like, oh, hey, dinner's ready. And he'll come down and he'll fix his plate and he'll sit with us. And I'll be like, why aren't you eating? He's like, I'm gonna give my insulin a minute to work. I'm like, good job. You know, like, but I forget sometimes, you know, but he's doing the right thing. He's letting, he gave insulin. He's got a lot of work too, to match up to that blood sugar level. At home, that's what we're gonna strive for with our patients. That's what we're gonna teach them. If you're in long-term care, you're in acute care, guys, it's almost impossible to do that. First of all, you've got too many patients. Trays get there, everybody's got a tray, and I can't safely go give you insulin as fast as I can pass trays. There's also things going on too with our patients. For an acute care, they're sick. They might not be eating. They might be in PO for procedure. There might be something else going on. Sometimes somebody is like, they have orders that will say, count their carbs, see how much they eat, and then give them insulin. But they don't want to give them more. So we're giving it after, but we're making sure we're not giving them too much insulin. So we work with whatever we have. I'm just telling you guys, best practices are to give it before. You probably won't be able to. What I want you to know is, let's say you give somebody regular insulin. When should you go back and check on them?
2 to 4 hours.
Right, when it's peak effect, right? Because we know they ate in about 2 to 4 hours, so let's just say 3 hours. I want to make sure I'm looking at them. I don't necessarily need to check their blood sugar at that time, but I know that insulin is having its peak effect. How are you doing? Okay, cool. I'm just checking to make sure that they're doing okay at that peak effect. We talked about, okay, there's also long-acting insulins. So guys, when I was this is how old I am. When I graduated, we did not have long-acting insulins. We had NPH, like a mixed insulin, which is hardly ever given anymore. So there's Levemir or Detamir and Lantus. Those are those long-acting insulins. Guys, those are amazing. So I think, did I talk about the pancreas being the leaky faucet already? Oh, I forgot. Oh my gosh, guys, it's my favorite little analogy. Oh, I'm sorry. Okay. The beta cells of the pancreas are like a leaky faucet, meaning that you guys all have a faucet, like a sink that kind of had a leak to it. That's what your pancreas does in the beta cells. It just leak, drip, drip, drip. It's dripping out a little bit of insulin all the time. All the time. Because just for basic functioning, we all need glucose a little bit in our cells, even if we're sleeping at night, not doing anything, right? We all need a little bit of glucose to keep our organs going. When we eat, right? I get hungry, and I drink my tea, and I eat my sandwich or whatever. The faucet opens up, and it dumps out all the insulin that we need. And then it closes right back up and goes back to the little leaky faucet. Drip, drip, drip. That's how the pancreas normally works, right? People with diabetes, it doesn't work the same. So I'm so sorry, I forgot to tell you about my drippy faucet, leaky faucet analogy. The long-acting is such a great insulin because it mimics the drippy faucet, where it doesn't, look at the peak action. Do they have peak actions? I think one of them does, right? Kind of has a bit, I think one of them doesn't. Yeah, they really don't have much of a peak, right? Like it kind of just, we're going to do some timeline work in a little bit, where if you think about regular insulin, you give it, and in about a half hour, it's starting to work. It's going to peak up in about 3 hours and then slowly go out of the system. That's that leaky faucet when it opens up, right? That's like the bolus, like giving you a bunch. The long-acting insulins, they're like the drippy faucet. They are not, they're just mimicking a little bit of insulin that we need all day long. They don't have like a big peak effect where suddenly a lot of it's working. It's just a little bit at a time. It's amazing that these were developed, because before that, I'm not even going to get to like Novolog or 70/30 and the cloudy insulins. Like they were just a mess to try to figure out who was the peak and how. I just feel so, my heart hurts for these diabetics who are trying to manage it with these older types of insulin. We're so blessed to have this to give to our patients now. So most times, patients who are on insulin at home, will do like, it's called basal bolus scheduling. I think that was in our homework this week, where you have the basal, you get the leaky little bit of insulin all day long, and then you get a bolus, a bigger amount of short acting or rapid acting insulin when you eat. If they have an IV pump, the pump is similar, but it doesn't have a different type of insulin. So my son wears a pump and it just has, I think he's on Humalog right now. So he's on one of the rapid acting insulin. The pump is programmed to give him little leaky doses all day long. They just leak out. And then when he eats, he tells it he's eating, and that's when the faucet will open up in the pump and it will give him a bunch. And it goes back to just, but it's just one type of insulin that's in that pump. Okay, let's see, where else we're gonna talk about. Insulin sites. You guys learned when you're giving sub-Q injections, you gotta rotate around. I know they're very specific and like ATI is like, this is where you can go. You can go anywhere where there is subcutaneous tissue, right? So if you have fat on your collarbone, you can give insulin on your collarbone. I wouldn't necessarily do that, right? There's a lot other better choices. But the point I'm trying to make is make sure we've got there's a lot of landscape to use. And what's a complication that can happen if we just use the same spot over and over? Yeah, scarring, tissue damage. Because that scarring and tissue damage, the insulin will not be absorbed as well. It's going to be longer. It's not going to work like it should. So we want to make sure we're rotating through. I've had several patients that I've in my career taken care of that oftentimes will ask me to give like the back of their arms. They go, I struggle giving in the back of my arms. So will you do that for me while I'm here in the hospital? Because it's kind of a new spot for them. It's one that's not used very much. Because usually like the belly is pretty like, that's right there. That's usually people's favorite spot. But the legs, the bottom, all over. I keep putting this down, forgetting where I put it at. Okay, these are insulin pens. You guys practice with these in the lab already? Okay, you know how to dial them up. What's one thing that's important to do before you give these, before you dial it up? Prime it, right? Because there's air in there. Got to make sure we're giving them actual insulin, not just some air. This is a type of insulin pump. This is a tubed pump where, yeah, look at these little sweethearts. But this type of pump, they have a little device that's on the skin, and then there's a tube that goes to a little machine. So you can see back here, this is the part that goes into the skin. And it doesn't show the tube, but this is a little machine that has like the insulin inside of it. The nice thing, sometimes people really like these because you can unattach, like where the tube is inserted into the little device. You can unhook it and then go shower or do whatever. Some people really like that. When I asked my son what he would prefer, he really wanted this all-in-one device. This is him. But it just all is in one. It sticks out a little bit more. But he didn't want to have a tube that it would like get snagged on and pull, things like that. It's really nice because the technology, I mean, it's always advancing, even from when he was diagnosed several years ago to now, it's advancing. His pump that he has now connects with his continuous glucose device. And so there's technology that's trying to mimic what our pancreas does. So as his blood sugar was going higher last night, his glucose monitor was sending that result to his pump. And his pump was going, okay. And instead of that normal trickle that it did, it was giving more trickles, more extra trickles. Now, it wasn't giving enough trickles to like keep it normal, but if it hadn't been, his blood sugar probably would have been like 500 or something instead of 300. Same thing, when his blood sugar starts to trend lower, it will tighten up that faucet, and instead of trickling, it just like barely gives any because it's sensing that the blood sugar is going down. It's not perfect. It's not like our pancreas works, but it's getting better. So I'm excited to see what happens in the next 5-10 years with this. It's really exciting. Okay, talked about these peaks. When I say timelines or like peak action, this is kind of how I see it. And what I mean by like these timelines, and we're gonna practice doing some of this. So this way is time in hours. So this is the beginning, and this is like how long it is. This is insulin effectiveness, right? So if we think about the leaky sink, this is like these ones here that shoot up really fast and come down. That's like the faucet getting turned on, that bolus. Lot. It's like, this is probably, yeah, this is Lispro, Aspart, Humalog, those medicines. It starts working really fast, peaks up, and then gets out of your system, right? Which is good, because if you think about, if you're taking it when you eat a meal, right? When you eat a meal, your blood sugar is gonna go up, but it's gonna go back down pretty quickly. It's probably not gonna, you're not eating constantly. Short acting or regular insulin, see how it goes, takes a little bit longer to get up and takes a little bit longer to get out of your system. There's not a lot of people that use regular, you're still gonna see some regular insulin out there for basal bolus, but a lot of people are switching over to Humalog, Novolog, Aspart, because it's so much faster in working, it gets out of your system faster. So I think we're gonna see as people are being diagnosed, I think we're gonna see more people on these medicines than we see in regulars. This is that NPH I was kind of telling you about. This is what, so we'll go back to NPH. Let's put a pin in it. We'll come back. So here we have Detamir. That's that like dotted line. It doesn't start working right away, but by golly, it just stays there and then kind of pitters out a little bit. And then Glargine, or is that Lantus? I think so. Detamir is Leathermere, Glargine is Lantus, yeah. It takes a little bit even longer to start, but then it's really just kind of solid, working constant. Those are the two drippy faucets, a little bit at a time. That's that basal insulin. So usually you get a rapid acting or short acting and a basal or long acting. You take both of those. When would you take the rapid acting?
Right before.
Right, when you're eating, right? When do you take the long acting?
In the morning.
Yeah, it just depends. Some people take them every day in the morning, some people take them every day in the evening. It's important you take the same time every day, right? Because there's a little bit of overlap of how it starts, right? There's like, it doesn't always start right away. Sometimes patients will have it 2 times a day, morning and night, so that there's a little bit of overlap with how it's starting and then wearing off. That makes sense? Yeah.
Does it affect that rebound effect at night if you take it at night?
Not usually, not unless you're going low, like if you had too much insulin or something else that caused you to go low. Not usually. So here's the NPH I was kind of putting a pin in. Before, when I graduated, we didn't have these red insulins. They were not even created yet. So what they would do is they would give it NPH twice a day to try to have this like overlap that would kind of work as a leaky faucet. It wasn't really effective because it really did lower the blood sugar quite a bit, and it didn't really last really long. Not very effective. So anyway, I'm glad we don't really see NPH anymore. NPH had the P was for proteins, I think. Anyway, so just know it was a cloudy insulin. Did you guys learn about drawing up cloudy insulins in? Okay, here's the deal. A lot of times I hear that students get asked about how to draw up insulins on their NCLEX. In real life, you're probably not going to ever have to use it because we don't use NPH anymore. The thing about NPH, it's cloudy, there's proteins in it. The proteins are what make it absorb slower. That's how it got a more long-lasting effect. Just know you draw up clear before cloudy. There's a whole thing in the weekly resource page that shows clear before cloudy and some other stuff in there. But if you get a random NCLEX question about drawing up insulin, you draw up the clear before the cloudy. And if you want to know the reason why, you get the clear because the cloudy has proteins in it. That longer acting, the NPH has proteins in it. We don't want to accidentally draw up the protein cloudy one first and then contaminate the regular or clear insulin with those proteins. That kind of makes sense? So, insulin pens are different. Ah, great question. So when you put insulin in the fridge, it looks cloudy, but that's actually the, what's it called? The condensation on the outside of the bottle. The inside of it isn't actually cloudy. But yeah, great question. Where do we store insulin? In the fridge. When we take it out, how long is it good for? 30 days. 30 days. If we have insulin that's left out in the sun, what do we do with it? You should discard it. I know there have been times when I've had insulin that was left out and I'm like, "Ooh, that's your lifeblood." And I'm like, but we can't trust it, right? You don't know how effective it's gonna be. Okay, insulin timelines. So let's let's do it. Let's go ahead and make 8 groups because we're gonna stay in 8 groups later for some work. And I've got up here, and then there's 2 pictures or 2 papers on the wall here, over here, and in the back, and then we'll do this side over here. And what I want you guys to do is kind of write an insulin timeline. So meaning, what I'd like you guys to do is use one color to represent the blood glucose. So let's say, I'm gonna say like B for breakfast, L for lunch, D for dinner, HS for bedtime. The green is gonna be the blood glucose. So I'm gonna say at breakfast, the blood glucose goes up. At lunch, it's gonna go up. At dinner, it's gonna go up. I'm probably gonna be hungry at night, so I might even like do a little snack. I don't know. And then I'm gonna give you guys an insulin order or an insulin regimen. And I want you guys to draw in your other color the insulin effect, right? So if I said, you're gonna give Novolog with meals, I'm not even gonna give you an amount, right? Just Novolog with meals. I want you to draw out, it should kind of be like, hey, the Novolog hopefully will match kind of the effect, like the blood sugar going up. And then maybe they get Lantus as well. I want you to draw out what that looks like. Kind of makes sense? A little bit? Okay. I don't care who is in what group, but I just need people at every paper and then. Actually, let's do the one board over there. Right, so we can go. Beautiful board meeting. I need some people up here at this poor little board. Nobody? I don't care how many people. Okay, well, wherever you want to be. All right, so let's go ahead and draw out kind of a graph for breakfast, lunch, and dinner for the glucose. So draw out kind of as people eat. Like, it's gonna kind of like it did under, it's gonna spike out for breakfast, lunch, and dinner. Just like I did here.
It's fine. She'll give us something. You'll be able to buy it, and it'll be.
Okay. From here, right? From the 7 o'clock. Sorry. Writing down like. Yeah. That's right. Well, you guys understand. No.
Yeah, 7, 7.
Family brought, and then we're like, hold on. Yeah. When you're. And you're like. I think I have to get some of that. Don't make me say I don't. It's not a yes. You don't mind. I just.
Like this is me. This is me.
Okay, so thank you guys for doing this exercise. A couple of things I want to point out, and I've talked to some of you guys, is that you, first of all, I think most of you guys have made the connection where as we eat, our blood sugar goes up. We want the insulin to match that, right? We want we want the insulin to kind of match as the blood sugar rises. And then as the blood sugar starts to go away or go down, we want that insulin to kind of go down as well. Because what we see on here are big peaks. What we see inside of our bodies, it cancels it out. Because as we eat, our blood sugar goes up and our pancreas releases that insulin. So instead of peaking up, it's steady. It's nice and steady. It cancels each other out. In our diabetic patients, it's peaking. We're following it with insulin. That's why with our diabetic patients, it's a little more wiggly because it's imperfect. We're trying, but it's not perfect. But hopefully, if we can get things to peak together, blood sugar and insulin, it keeps it actually lower. Okay, how about let's take a break and then come back at 5 after, and then we'll finish up class.
You're standing there, you're like. I was like,
So let's think about this, especially thinking about how we talked about insulin peak effects and stuff. You're working and you administer a dose of pre-meal insulin, Lispro, to Mr. Romano or Miss Romano. Her pre-meal glucose was 110. Your heart skips a beat because you realize you administered 30 units instead of 3. Yeah. All right, so think about it for a second. Turn to your neighbor. What do you do? All right, let's compare with what we're saying with what F.A. Davis says. So immediately we need to notify somebody, right? We also, what it doesn't say is that check on the patient, but hopefully we're right there. We can see what they're doing right now. But right now is not really what we're worried about, because what are we worried about? When it peak effects, right? That's a lot. So we know that we're going to be giving her extra carbohydrates or things to increase her blood sugar, maybe even IV if we can't get enough by mouth. We're going to monitor, and then we're also going to explain to her what happened, because even though it was a mistake, she has a right to know why things are different now. Why are you giving me all this sugar when before you told me not to eat all this sugar, right? Like, we need to explain that to her. We want to remember that Lispro is rapid acting. So glucose is going to start to drop within 15 minutes and up to 4 hours. It's going to probably be remaining low because that's that duration of action. They call it a level 3 event. We're not going to talk about the levels of event. We just know it's serious, right? We need to monitor. And then once she's stable, you need to fill out an error report. So let's say you're going to give an SBAR handoff to somebody, right? This happened on your shift. Let's say we're 4 hours into it or 6 hours, she's doing okay. You need to give handoff report to the next shift, right? We got to own our mistakes. We're all going to make some sort of mistake. Hopefully you guys will not make this mistake, but we still need to let other people know so they can keep monitoring or continuing care. So give SBAR report to each other based on these events.
Let me see. I probably.
I know, I can't.
Before lunch, I checked her sugar and it was this number. So I administered this amount of 30. However, I noticed that was way off from what I should have administered. Right, even if it were already. And then we got some carbohydrate for her. We got high. So we just monitoring that. And she's not
All right, let's compare what you guys say to what FA Davis recommends too. So situation, we're gonna own up to it. I accidentally administered 30. Background, she has type 1 diabetes. Her blood sugar had been this. You know, like I said, I gave you a scenario of 6 hours from them, but we would say, you know, I'm concerned about she might develop hypoglycemia. Will you work with me to contact the doctor's orders for carbohydrates? So this is a little bit different than giving us 6 hours after, but hopefully something kind of similar, especially in the beginning. We're kind of talking through the situation. Don't necessarily answer up here, but think about what about if you gave too much Lantus? What about if the order was for, you know, 5 of Lantus and you gave 50 of Lantus? Turn to your peers and kind of talk about how would your reaction to that situation be different than the Novolog situation?
Higher and longer. Or not longer, but higher.
because this one is but it's not a high.
Yeah.
So that's running the this could be like a shutdown. Because it's going to you already gave it.
All right, so hopefully in discussing with your peers, you guys have come up with not only are we monitoring the blood sugars now, but we're gonna have to be monitoring it for probably 24 hours, much longer. How do we manage that over 24 hours, do you think?
Continuous strip or.
She might need IV glucose, right? Well, what'd you say, Rachel? Or somebody. She's your Rachel puppet. Right, yeah. Right, because that's a great point. She probably won't need that short acting insulin, you know, and which would be a great idea to help keep more level than it is. So anyway, it's just a thought exercise to help us understand these insulins, because I think a lot of times when we're beginning in nursing school, we just think about insulin as like lower blood sugar, and we don't think of the nuances of how some of them work very fast, some of them work very long. You know, it's all very different. All right, so quickly, we're gonna talk about carb counting. You guys might have to do this. When we talk about people with carbohydrates, most of the time when people talk about a diabetic diet, a lot of the time it's consistent carbohydrates, meaning that they want to give you kind of the same amount of carbohydrates with each meal. They don't want to give you a huge waffle and a muffin and a cup of fruit and juice with breakfast. And then maybe only have like rice as a side for lunch, and that's your only carbs. You want to be consistent with how much carbs people take in through the day. Because what are carbohydrates going to do to the blood sugar? Raise it really far up. We want to try to keep it consistent for people. So typically 15 grams of carbohydrates. Sometimes they talk about the exchange system. I don't love it. I just like sometimes they just call it one diabetic carb or something, but they sometimes will say exchange. 15 grams is usually about a serving of a carb. So like a cup of juice, an apple, a serving of rice, those are usually 15 grams, okay? We're gonna do a little bit of practice. So let's say this is a tray that our patient gets. What carbs do we identify on this tray? Yeah, bread, apple, juice, and then somebody said potato. What about this over here on the side? What is that? I think it's mac and cheese. I think it's like pasta. Yeah. So if each of these are one carb exchange or one serving, let's count about 15 each, right? So here's 15 plus 15 is 30. Another 15 and 15 is another 30, so that's 60. Plus the potatoes, that's 75. That's kind of I think that's more carbs than usually patients will get, but it's good to know, right? Let's look at this tray. Oh, this one isn't as good. What carbs do we see on this tray? Potatoes, yeah. But is the chicken a carbohydrate? It's a protein, so it's not going to affect their blood sugar as much. Just a side note, fat and protein will increase the blood sugar. It's slower and much longer. So typically we're not going to count it, right? We're not going to worry about it with our normal things. I do know from personal experience when my son eats things that are very like a lot of protein, a lot of fat, I have such a hard time keeping his blood sugar low because they also can increase it. But for most of what we do, we just look at the carbohydrates. So chicken, the protein, that's really not going to increase the blood sugar a lot, but those potatoes will. What else on here? Fruit. The fruit. And then, right, what is this? So it looks like apple juice. It could be iced tea. It could be, so it's so important we look at the trays. If you are working in long-term care or acute care, most of the time the trays will have a list of what's on there. Sometimes it'll even say how many carbohydrates are on that tray as well. Because for certain diabetics, we give them insulin based on carbohydrates, how many they eat. Sometimes they'll say, hey, you get 2 units of Novolog for every carbohydrate exchange, right? So for this person, let's say they have potatoes, fruit, and this is juice. That's 3 exchanges or carb things. So if they're 15 each, how many is that? 45. If they get 2 units of Novolog for each 15, how many units of Novolog do we give them? It's 6. I know you guys were like done with dosage this morning, but this is the type of thing that you have to do with diabetics. Like dosage is so important. Like you're always doing math, which is another point I never really got to earlier. There's a study, I think Stanford Hospital did or Stanford University, and it was looking at diabetics. And this is why I think diabetics have such a hard time with compliance, because a lot of times we see diabetics come in, their blood sugars are out of range, they didn't do what they were supposed to. But they looked at diabetic patients and they had to make about 250 more decisions every day than the average person. Because they had to think, okay, when I get up in the morning, what is my blood sugar? Okay, I want to eat breakfast. Well, but how many carbs are in there? Okay, how much insulin do I give myself? I want to go for a walk, but what is my blood sugar? Do I need to take a snack beforehand? There's all those decisions and all those steps. And if you think through what even 5 minutes of that could be like, imagine a whole day or a lifetime. You can see how people can kind of fall out of compliance or doing what they know they are supposed to, but it's so much to carry with them, which is why I'm so thankful that we're getting these continuous glucose monitors, we're getting insulin pumps, we're getting insulins that are better at controlling them because it makes it easier for these patients. Okay, we're almost done with this. Oh man, I forgot. Desirable pre-meal glucose is going to be 70 to 100, right? That's kind of a nice little sweet spot for before you eat where we want you to be. Exercise, so just know for our patients, we want them to exercise, but we need to make sure that we know that exercise can lower blood sugar up to 2 days. That's pretty good exercise. And make sure they've got a snack. That we usually tell people if you're below 90, maybe below 100, have some extras, have a snack with you, especially if you're like you work out for a long time, you're going to go maybe the runners, right? That like they go run miles. Well, if you're miles away from home, you need to make sure you've got a snack with you that you can easily access. We want them to exercise. We just want them to know, hey, let's be smart about this as well. So complications with diabetes are broken down to macrovascular and microvascular. So macro, what is word building? What is macro? Big, right? Big. Vascular vessels, right? The blood vessels. So big vessels and micro is small vessels. So we look at the complications for diabetes. Usually it's in our big blood vessels or the smaller blood vessels. Big blood vessels, we can see things that happen with peripheral vascular disease, like we talked about earlier this term, but it also can have some, makes you more susceptible to having strokes or heart attacks. Those are kind of the macrovascular risks that you have. There's also microvascular changes like retinopathy. So that's when our retina, right? There's like a neuropathy or like where the retina gets damaged because of uncontrolled diabetes. And also nephropathy, what is nephropathy?
Kidneys.
Right, kidneys, right? The kidneys are getting damaged because of the blood sugar. Long-term can also, the neuropathy, the nerves, they can be damaged, can lead to infection, a lot of foot problems. Let's see, name that neuropathy. I don't know if I already did this or not. Oh man, I did. Okay, so I'm so sad, guys. Let's just talk through it though. Numbness and tingling in the feet. What kind of neuropathy? That's a sensory neuropathy, right? Because these patients are gonna, if their blood sugars are uncontrolled, doesn't mean diabetic patients will always have these. But if blood sugars are uncontrolled for long enough, they will develop these eventually. So that's why we try to teach them how to control it so they can prevent these from starting. But they can have sensory neuropathy where they get numbness and tingling in their feet. They can also have some motor neuropathy, their motor skills, the muscles. They can get some weakness in their hands or elsewhere, right? Weakness in hands is just an example. Sometimes they can have nausea, chronic nausea, and that's autonomic neuropathy, right? Our autonomic system, like the digestion, sometimes there can be like, it's not working as well with our diabetic patients. It slows down their digestion. And so we can have patients who have diabetes who are chronically nauseous because they just have the slow digestion. Sorry, I should have given you a little pre-warning, but this is a diabetic foot ulcer. I still remember I was in the hospital that my mom was in a couple of weeks ago. I was walking by one room and I had this flashback to nursing school because it was one of the hospitals I did my clinicals at. And I did a rotation with wound care and there was this homeless man with his foot. And, she had like a, the long Q-tips that they use to see if there's tunneling. And she was pushing it through his foot or his toe. Boop, 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 and then it came out the other side of his toe. And I was like, oh, as a student, I never forgot that. And then when I walked by that room when I was going to see my mom, I was like, oh, I remember like that. Like it was so crazy. Like you'll see things you'll never forget. But with our patients with diabetes, we always are concerned about their feet. Because remember, we talked about the heart, the furthest away from the central is what's going to be affected the most, or the first anyway. Our feet are usually the most affected by lack of blood flow, damage to the nerves, other things that happen. And so our feet are really important with our diabetic patients. Oh, that's they lost their big toe. That's where the big toe should have been. So that, and then there's also this one we see a lot with our diabetic patients. Why do you guys think they're developing these?
They can't feel it.
Got it. Because think about you or me. We go buy a new pair of shoes. They're cute. We're walking around all day and we realize, oh, it really is hurting. It really is bothering me. Am I gonna put those on tomorrow and wear them all day again? Probably not, because it hurts, or I'm gonna do something. Our patients with diabetes, if they have some neuropathy, they can't feel as well, they can start developing these and they don't know. And then they keep doing the same thing and it keeps getting worse. One of my biggest things with my diabetic patients is I ask them, do you look at your feet every day? And they're like, what? And that irritated me so much. My son was first diagnosed. They had a home nurse call me and she goes, well, is he looking at his feet every day? And I was like, he's 15. I'm just trying to make sure he looks at like his armpits. Like, anyway, anyway, it wasn't really applicable for him at that time. But as we get older, if you start to have neuropathy, our diabetic patients should be inspecting their feet every day because we want to have them look, is there any redness? Are there any blisters that are forming? Are there any skin breakdown? Is there anything going on? We usually tell them, like they'll talk about diabetic shoes. Usually for diabetic patients, we don't like them to have open-toed shoes or sandals because little pebbles or rocks can get in there and they might not feel them. And they're just walking around where you and I would be like, ah, it hurts so much. They don't know. And then it can develop into something like this. They don't even know. So that's why it's so important that our diabetic patients look at their feet every day. I say every day, I figure if they do it 3 times a week, hopefully that's good enough, you know, but really they should be, or they can't look at their feet very well. Get your loved one, right? When you go see your dad, like have dinner, then go look at his foot or look at it first. I don't know, whatever you want to do, but like check on them. That's one of the biggest complications. So we want to teach them, look at them, wash them and pat them dry, right? Keep them really dry. Good fitting shoes. We usually say, hey, avoid crossing your legs. You know, we don't want to cut off more circulation. And then nail care. You'll notice that sometimes, especially long-term care facilities, they won't let just anybody cut the toenails because there's such a risk of causing damage there, infection. A lot of times they have to have a doctor, a podiatrist come cut the toenails. Smoking cessation. Think for a minute. A lot of our diabetic patients also smoke. How is that going to affect their diabetes, their blood vessels, all of that? Vasoconstriction. How's that going to affect like wound healing? Right? It's going to make it even worse. So it's important we explain this to our diabetic patients, especially if they already have some wounds. Be like, listen, it's not that I just want you to stop smoking because I don't want you to have something fun to do. It actually is harming you, you know, like explaining that to you. It's so important. Surgery, just know if you have patients that are going to have surgery, we're going to probably have to do something different, right? Like my son, he's going to have his nose fixed in like 3 weeks, I think. They're making sure he's first one on the schedule, right? So our diabetic patients, we want to have them go first on surgery because you can't eat or drink anything, right? You're NPO. And we don't want to keep our diabetic patients NPO for longer than we need to because it's so hard to control their blood sugars anyway. So just know diabetic patients who are going to have surgery, we're going to watch them. Anytime they come out of surgery, if you guys work in a pre or post-op type unit, you're always going to be checking the blood sugars before and after. I don't know. Think in your head, what's a diabetic self-care education point you would teach? Sorry, guys, I meant to delete all this. All of it. One thing we didn't put on here, though, I didn't talk about actually the medical bracelet. So we talked some in the program about like medical alert bracelets, right? They're really important. I always stress for diabetics too, especially in this day and age and where we live, where we're going to school, there's a lot of drug addiction, drug abuse, misuse. Think about the signs of low blood sugar. A little bit delirious, slurring speech, not doing things quite normally. You might be mistaken. My son drives me crazy because he refuses to wear a medical alert bracelet. I said, buddy, if something happens, they're not gonna think that your blood sugar is low, they're gonna think you're high. And he's just like, oh, well, then there's some things as a parent I can't make him do, and it's really hard. I wanna spank him, but he's bigger than me. So anyway, it's so important though, like, and I love when his doctors, he goes into his doctors and they say, where's your medical alert bracelet? And I love it when it's not people than me, because it's not just mom saying you should do this, right? But it's so important that they know, like, hey, if you got to find out ways, you're gonna let people know so they can treat you. Just like if people take Coumadin or like, bleed, like blood thinners, they should wear a medical alert bracelet too, or people with seizures. Just so if you are a healthcare provider, you have a little bit of information to take care of them. Okay, I think that was all. Let me stop this recording.